Okay, I want to thank you, Matthew, and thank everybody for who's tuning in this evening to NAMI New York City Staten Island's Community Information Webinar. My name is Pete Schiffman. I'm the president of NAMI New York City Staten Island. And it is my pleasure to introduce our panelist for this evening, Matthew Shapiro, who is the Director of Public Affairs for NAMI New York State, our parent organization. Matthew has worked for NAMI New York State since 2008 and currently serves as Director of Public Affairs. In his position, he oversees NAMI New York State's advocacy and communication efforts. He is co-author of NAMI New York State's recently released Meeting a Mental Health Crisis with a Mental Health Response, a report by NAMI New York State detailing how to maximize the opportunities associated with New York State implementing a 988 mental health crisis number. Matthew is the host of the NAMI New York State produced video series Perspectives, and is a frequent guest on Capital Region television and radio programs to discuss mental health issues. He has also presented at numerous national conferences and conventions. Matthew serves on several prominent state and national steering committees, and Matthew is the recipient of the 2019 NAMI Richard T. Greer Advocacy Award, the 2020 Star Coalition Star of Excellence Award for Advocacy, and the 2017 New York State Association for Psychiatric Rehabilitative Services Family Partner Award. Tripped over my tongue.
It's a little wordy.
So again, thank you and welcome, Matthew Shapiro.
Oh, thank you so much, Peter. It's great to be here. Thank you for inviting me to have this important and very timely discussion. So let's get this all set up. You should be able to see that. And I'm going to put this into presentation mode and we're going to be good to go. Present. We'll go full screen and we'll be off and running. So there we go. So really, as Pete said, one of the priorities for NAMI New York State for a very long time is addressing both suicide and the criminalization of mental illness. And Pete mentioned the report that we put out, and I'll discuss that in a little bit. But today we're really going to look a little more on the suicide side of it than the criminalization side. But we are very, very excited about 988 and its ability to address both of these issues that have had such a negative impact on our community. So it's very exciting. So again, as Pete said, I am the Director of Public Affairs for NAMI New York State. My email is there, and you'll see what we'll be discussing tonight. And this is just such a great experience. Whenever I can talk to my friends in Staten Island, it's very special to me. Staten Island has a big place in my heart. I think I've told a lot of people from the affiliate. Growing up, my mom had a store on Staten Island on Arthur Kill in Richmond, and spent a lot of time there. And it is a place close to my heart. And hopefully I can visit everybody in the fall and do an event in the fall and be there in person with everyone. I miss seeing everybody. And tonight's also a very special presentation for me because I want to dedicate it to the memory of Joan Raleigh, who I know most of you knew and loved, and she's a vibrant member of NAMI Staten Island and an incredible advocate and just someone who gave it their all. And you get choked up thinking he lost her life doing what she loved and was fighting to the end. And we're really picking up the torch for her, or picking up the baton from her on some of the issues that were so important to her, especially vis-a-vis hospitalizations and making sure there are hospital beds available. So, it's almost been, I think, a year since we've lost Joan, and she was a heck of an advocate and a great inspiration. And I just really want to dedicate tonight's presentation to her memory, and we should all continue in her spirit and continue her powerful advocacy voice. So Very important to me that I mentioned that. So getting into tonight's discussion, obviously I want to kind of give an overview. Most people in this audience don't need to know all, we live these issues. I'm personally someone who's been impacted by mental illness. I was diagnosed when I was about 3 years old, when I was still in preschool. I tell people I got expelled from preschool. So I've been in recovery my whole life. My mom has a borderline personality disorder and has been hospitalized several times. I have siblings that struggle with mental health and substance use issues. Luckily, my one has been recovery for a long time, very proud of him. But we know that we're not alone when we talk about these issues. Mental health has become more prevalent, throughout the United States and the country. I mean, you can see all the statistics here. I don't really have to get into it too much. But what is the ripple effect of this? I mean, and really having underfunded mental health services for so long and really undervaluing the need for mental health services and having appropriate access to services and Pete and I were chatting before we started, and taking care and making sure we have a vibrant and robust mental health workforce, which is really the backbone and the foundation, which everything we want to build on. So, there's been a lot of effects for this failure to properly address mental health issues, and we see it in so many different ways. I think, for us, the family caregiver aspect is so important, and caregivers can spend an average of 32 hours a week. It's a full-time job caring for somebody. And I say it all the time, the families and the caregivers become the safety net when we don't have adequate mental health services. So, that's so important. And, we see this in so many different ways too. Obviously, the homelessness issue, which is playing out in New York City in so many different ways right now. And I know Mayor Adams is trying to be very aggressive in addressing this issue in a very, I think, holistic way. And we'll talk about a little bit that in a minute. Obviously, very concerned about, the 37% of people incarcerated have a diagnosed mental health condition here in New York. It's actually about 64% of our incarcerated population has either a mental health diagnosis, a substance use issue, or a developmental disability. So, again, there's been so many negative effects of the lack of investment, and we're seeing it right here in New York. I kind of gave the global perspective, but digging down a little bit, we know that so many people aren't getting the care that they deserve. I mean, cost is one aspect of it, of course. Lack of access, not being able to find the services, and not having services available are also a huge piece here. So that's why, over 4 million New Yorkers live in a community that doesn't have enough mental health professionals. I mean, we're really calling these mental health deserts. There are whole counties in upstate New York that don't have services. So this has been a big problem for a long time. And again, so many different results from that. We're seeing, obviously, through COVID too, the rise in anxiety and depression and people with serious mental illness not getting what they need. And in a lot of ways, very disturbing what we're seeing in our youth today. And, when we have almost 150,000 New Yorkers aged 12 to 17, they have depression and they're not getting the services they need, that's a huge issue, because we know the earlier we can intervene and provide services and get people on the road to recovery, the better their outcomes will be and better their recovery will be. So it's been very challenging. And of course, for today's discussion, I mean, we discussed the homelessness here in New York a little bit, but, really what we want to focus on is the suicide here in New York and how we can prevent that. And in the past year, we lost over 1,700 lives to suicide. And we still have so many adults who have thoughts of suicide. There was a famous, more infamous study done by SAMHSA during the height of the COVID pandemic, saying that 1 in 4 young adults have seriously considered suicide and made a suicide prevention plan. So this is a very serious issue. And we know suicide is not the answer, and we really need to do everything that we can do in our power to prevent suicide and support families who have loved ones with suicidality, and support the individuals themselves. You know, one of my favorite quotes is from Elie Wiesel, who said, "To save a life is to save a generation," and it's so important. And it really starts with having discussions like this and realizing that it's okay to talk about suicide. You know, one of the things that NAMI worked on in the past so hard was introducing mental health education in schools, and so many teachers were afraid to discuss suicide because they thought they would be talking about it wrong, or if you introduce the concept, it's putting the idea in people's heads. But it's so important that we were able to have honest conversations and let people know that even though thoughts of giving up and thoughts of suicide are very frightening, whether you're experiencing them yourself or if you hear them in your loved one, you know, we have to take all of these seriously, and there are things we can do. And again, I don't really have to get into the prevalence of suicide. It's way too high. You know, one death is too much, but when you see that this is the second leading cause of death in young people 10 to 34, and you know, we see most, we've made such advances in medicine, we see most of the causes of death declining, the rates, whether it's heart disease, cancer, all these things that have been long-time killers, yet suicide rates continue to go up. And that's a real health disparity that we're lagging behind on. Again, just to point out, I think a lot of people are surprised when they hear that 75% of all people who die by suicide are male. I think traditionally men have been more reluctant to talk about their mental health issues and struggle in silence. And that might be one reason for that very eye-opening statistic. Obviously, those in the lesbian, gay, bisexual, trans community also have much higher rates of suicide. And you know, NAMI is doing very great work to support that community as well and bring their issues to light and see what we can all do to support that community, because it's so important that we don't leave anyone behind, and to know that suicidal thoughts are a symptom just like any other, and they can be treated and they can improve over time. So again, it's very scary whether you're having these thoughts yourself or you hear them in a loved one, but they can be addressed and they can be helped. And that really starts by you. I mean, it's something we say with at NAMI all the time, that hope starts with you. And it really, only by working together can we create a community that's rooted in mental wellness and really work to prevent suicide. I mean, it's part of what we call the NAMI effect. And it's, you know, what NAMI-NYS Staten Island does every day, and support groups and the signature programs, and really creating a community of wellness and awareness. So, you know, awareness is such an important part of this, and knowing what the warning signs are for suicide and what to do if you see those warning signs. So, you know, again, there's no such thing as a mild suicide mention, or, you know, anytime someone mentions suicide, it's something to be taken very seriously. You know, it's not, oh, that's just a kid being a kid or whatever. You have to take every mention of it very seriously, whether it's talking, writing, or drawing about death. A lot of times when I have been presenting to college campuses or to teachers, you know, I say if you pick something up in a report or a paper or something that triggers, you know, you have to take that seriously. And obviously, talking about having no reason to live, being a burden on others, not being here tomorrow, looking for ways to attempt suicide, feeling hopeless, depression, trapped. Giving away possessions is always a very high warning sign, and just behaving recklessly as well, and that type of dangerous behavior. And like I say, we have to take immediate action if we fear someone is suicidal. You know, ask the question. Don't be afraid to say, if you're hearing these sort of mentions, are you thinking about suicide? You know, be direct. We can't dance around this issue. You know, not are you a little sad, are you a little worried, a little anxiety? You have to be able to ask the question. And if they do tell you that they're suicidal, they admit it, don't leave them alone. You talk to people that you trust. Traditionally call the national line or call 911, but we'll be talking about that in a second, that's going to change and become much better. And, even not bring someone to an emergency room, but we're going to talk about the new options that are going to be available to New Yorkers. And obviously, we don't want to keep these things a secret either. So, this is one of the ways we talked about all the negative outcomes that we've seen from lack of investment. And that's why this year with our legislative focus and our advocacy focus, we really boiled it down to the three main issues: reimagining crisis and making sure New Yorkers get a mental health response to a mental health crisis, caring for those who care for us. I mean, the people like Pete and I mentioned Joan before, the people who every day dedicate their lives being on the front line to helping people advance their recovery. I mean, they're the foundation of everything that we want to build upon. And of course, increasing access to mental health services. I mean, we talked before about too many mental health deserts in New York, and we really just need to make access more readily available to all New Yorkers. It's so key. So, I'm glad to say I've been at NAMI, as Pete said, since almost 15 years, and this has really been the most positive budget we've seen, definitely in the 15 years I've been at NAMI, and a lot of that does go to the voices of our NAMI advocates who've been sharing their stories and talking about their experiences, and most importantly, putting a face to these issues and showing how these issues are impacting our communities. It's so important. And some of the positive results, an overall $800 million increase to the state OMH budget, brought it up to $4.7 billion. One of the things we've been fighting for, you saw it in the graph before, was the 5.4 cost of living adjustment for the behavioral workforce. So excited that got in. Investments for further staff retention, bonuses, and other things. Pete and I were talking before too, how it's been a struggle keeping the staff up at South Beach, and we're seeing that all over, whether it's in hospital settings or community providers. Keeping staff there, caring and knowledgeable staff has been a challenge, and we know that continuity of care is so important in recovery. Something I can't say this without thinking of Joan, because this is something she was fighting so hard for, was restoring the hospital beds that were lost during COVID. One of the things I got to work so closely with her on was, during COVID, at the height of the pandemic in the spring of 2020, Governor Cuomo at the time, put in a state mandate where all hospitals had to have 30% of their beds available. This is every hospital in the state, in case of another COVID surge. So when, things were so bad in New York, they can move people around the state based on bed availability. And many hospitals, especially many in New York City, really targeted both the mental health and detox beds to meet these needs. And we know, we've been talking about this for a long time, that one of the main reasons that hospitals have really looked to decrease psychiatric beds is that the reimbursement rates were much, much lower for psychiatric inpatient than it would be for a physical inpatient. And also, hospitals really make the most money for very acute services, surgical care, in and out, high turnover type things. And we know sometimes the psychiatric stay can take a little longer. So we're very, very excited to see $55 million put in to increase the Medicaid reimbursement rates for psychiatric services. That's going to increase the reimbursements by about 20%, which is very, very needed. Major investments in children's mental health initiatives, including both school-based initiatives. We talked about how kids are struggling right now more than ever before. And then, we talk about how there's a lack of regular mental health services. Sometimes, we joke in the field and say pediatric psychiatric services are almost like the golden unicorn. It almost doesn't exist. So the state is being very aggressive, both with trying to open up more school-based clinics, so kids can access real mental health care right in the school, and they can treat the families as well. And one of the initiatives too that's very exciting is trying to put more psychiatric providers integrated into pediatric primary settings. You know, that's also been an issue that we've been trying to advance, to have more mental health professionals in the primary setting. That way, you know, a lot of time, well, now whenever someone goes for like a physical, you know, you get that questionnaire that asks if you've been depressed. And if you say you are depressed, there's really not much they can do. They try to maybe send you to a provider and good luck getting an appointment. But if there was a social worker right across the hall, where once that got kind of red flagged, you can talk to somebody right away and they can help connect you with services, that would be a huge benefit. And you know, while we want that across the board, we are very excited to start to see it more with children's pediatric primary care. So very positive. We'll talk about some other in a minute. So some highlights for suicide prevention specifically. A couple of things. You know, one, the new CARES Up initiative, which, you know, the state loves these type of things. And this is one of the most oddly worded ones, but you see where the CARES Up is. And this is really to help veterans and uniform personnel, you know, police, EMS, firefighters. You know, we did a lot during the pandemic to try to address frontline mental health, and as NAMI, and now being the state Center for Suicide Prevention Center for New York, really launched this initiative for veterans and for frontline uniform personnel is so important. You know, again, kind of talking about kids a little bit, something that's really exciting, and we'll talk a little bit more about ACT teams in a minute, but $21 million to create the nation's first assertive community treatment teams dedicated to children and their families. And you can see here, Staten Island's going to have a 36-slot team organized by the Jewish Board of Family and Children's Services. You can see the other services being offered in New York. I don't know if anyone's not on the island, maybe a couple people from Brooklyn or something, but very, very, very positive. You know, a lot of times, you know, give the example of a friend I have here in Albany who has had a teenager with serious mental health issues, and brought her to the psychiatric emergency room here in Albany, and there was no beds, and she got moved all the way down to Westchester, and it just a nightmare situation. But if she could have called and had a assertive community ACT team that's dedicated to children and their unique needs, that it would be tremendously beneficial. You know, when I mentioned this to her, she goes, I can't tell you how much something like that would have helped me when Rose was in crisis and needed those services right away. And so this is a very, very positive initiative. And, you know, one of the major investments that you've heard us talk about is really New York reimagining mental health crisis situations and really assuring that we get a mental health response to a mental health crisis. And, you know, again, it's not a panacea that's going to cure everything, but it's certainly going to address a lot of these issues that I mentioned leading up to it. So as we talked about before, you know, NAMI's been working on these issues for years. This has been a high priority for us. And in the fall, we released a whole report about this. I will put a link to the report at the end if people haven't accessed it before. It's, you know, not only very informational, but like I said, you know, it's always so important that we have the NAMI member voice in our advocacy efforts, and along with detailed information and what we want to see in a mental health crisis system. It also contained our family stories and the stories of our members who've had negative experiences when calling 911 or dealing with first responders, and really showing how this is affecting New Yorkers. And, you know, we've been so lucky that the state really listened and really took many of our recommendations or putting them into action. So what they're really doing is creating a fully functional crisis response system. And that's a really kind of a radical concept when you think about it. We talk about how all the time how we talk about a mental health system that doesn't really exist, right? It's a bunch of disjointed services that, aren't always linked together. It can be very confusing, but this is a real effort to create a coordinated crisis continuum and a real system of care that's going to address, like I said, both suicide and the criminalization, and really divert people away from to the criminal justice system and towards recovery and services and support. So, the three basic elements that are a part of this system of care are, who do you call and making sure there's someone to talk to, who responds to these situations when a response is needed, and where to take somebody if they need to leave the place where the crisis is taking place. So we'll be looking at each element of that, starting with who to call. I'm sure most people guess, I've mentioned it several times already, but 988, the mental health crisis line. And what we really keep saying is that 988 is much more than a number. It really is a gateway to help, hope, and healing. And that's the mission right now, is to really educate people on this and really show how powerful this tool is going to be, and how it really can guide people towards those three things that are so important: help, hope, and healing, and of course recovery as well. So starting July 16th this year, you can start to call 988 instead of 911 during a mental health crisis situation, and receive a genuine mental health response to a mental health crisis. So what are we actually talking about here? So you can see here that this is going to be a service for anyone who's suicidal, experiencing a mental health or substance use crisis, or any kind of emotional distress item. Basically, there is, the 800-273-LIFE line that exists nationally now, but that's really specifically designed for suicide. This is going to really expand on that and make it a lot better and make it a lot more all-encompassing. And again, the other message that we're really trying to have people resonate with people is that 988 is not going to just replace 911. 988 is going to improve on 911 for those experiencing a mental health crisis. When you call 911 right now, you get connected with an operator. Their job is to assess the situation and send someone to respond. Usually if you're a typical 911 call, a couple of minutes, right? They find out what you're located, try to figure out what the emergency is, and send the right people. Well, this is going to be a lot different. When you get called 988, you're not going to get a dispatcher. You're going to get a trained mental health professional. This could be a social worker. It could be a licensed mental health counselor. It could be a psychiatric nurse practitioner. It could be a peer, a peer specialist. They're going to be the ones on the other end of the line. And they're going to be able to hopefully de-escalate the situation over the phone. They will stay on the phone with you as long as is needed to either de-escalate the situation, or if someone is needed to respond, they're going to make every effort to make sure that it's a mobile mental health team and not police responding to the scene. And it will be a handoff situation too. So when the responder gets there, they'll also be able to talk to the professional and get a better handle of what's going on with the situation, as well as how to best communicate with that person. So it really a radical difference. And just to be clear, who can contact 988, it's so important to understand, while this is going to make such a difference in preventing suicide, it's not just a suicide helpline. It's really a service for anyone who might be in any sort of a mental health crisis situation or emotional distress, and it is open to anyone, and that's what's so important. But what's also important is the funding for it. When we were advocating for this and for the past year and a half, really pushing for it, what our argument was, and what's stated in the report, is that we want to make sure that there was, for 988 to be fully functional and help the people it's designed to help, then it needs to be available 24/7, 365 days a week. with all in-state providers. We don't want people in New York calling 988 and getting someone in California or New Mexico, I mean, whatever it might be, that you're getting somebody who's located within New York State, who has the ability to provide the person with local resources in their community for follow-up if the situation could be de-escalated. And we wanted to also make sure that that we have the workforce to handle this, and that these services can be delivered in both a linguistically and culturally competent way. And obviously, that's an expensive lift. And you know, the number that we had in mind kind of going into this year was about $60 million. And we're really excited that that need has been met and those investments are being made. So right now, there's a 2-year funding direct from the governor's budget for this. So, you know, again, this year, so for July, from July to April, because we have our state budget year, fiscal year goes April to April. So, you know, the line is going to be going live in July. So it'll be up for about 75% of this year. And we know it's going to take time for people to get accustomed to using 988. We talked about the importance of educating people around 988 and how to use it. So we know it's going to take about a year for the line to get the utilization we want to see. So when you factor in that it's going to be growing and it's only going to be used about 75% of the time, 35 million for this year is appropriate, which is going to grow to 60 million, which was the number we were shooting for in the next fiscal year. And then there's some other investments being made in 988 through both SAMHSA, you know, this Substance Abuse and Mental Health Services Administration, as well through mental health block grants. That's the MHBG, you see. So New York is really one of a handful of states that's really investing in 988 and implementing it correctly. And to kind of show an example of this, you know, this is right now. This slide was from Tuesday's presentation. You know, NAMI participates in OMH's 988 planning group. So here you can say, you know, the last time they showed this slide, it was in February, and you see this white swath here, which is where there's no coverage. That actually extended all the way down. So all of this here is new. So right now, if we were to flip the switch on 988 today, New York would be able to handle about 80% of the calls being made to 988. And they're very confident that come July 16th, that will be to 100%. They have calls for proposals and are working on these few counties that still don't have it. But important to this conversation, we see New York City and Staten Island and Long Island and all our downstate friends that will be covered. So that's very, very positive. Also, you know, OMH wants to make sure people are stay up to date on this. So there is a newsletter you can sign up for. I can give the link for also in our e-news every week. So it's a great way to really learn more about 988 and the services around it. Another information thing that we're doing, actually in New York City, very excited to be participating in it, is the Sound Mind Music Festival for Mental Health. Has some big national artists on it, but this whole festival is being designed to raise awareness about 988 and mental health crisis services, which is really such an amazing thing. And we were brought on to really be help shape the education around 988 and how it's discussed at the event. So we're very excited about that. We're actually creating a whole bunch of new resources that will be launched at this event that we'll have available throughout the year as we educate people on this. And hopefully our friends in Staten Island will come visit us up in Albany for our conference. And like I said, come down to you, but we'll make those resources greatly available to everybody. So that's kind of the background on 988 and who to call. And now just kind of looking at the other two main pieces of the mental health response system, you know, who responds to these situations, and once someone responds, where do they go? So the two real parts of this, and again, the OMH is great credit. They see this as a full system of care. So They have investing in a lot of mobile crisis initiatives, which I'll discuss in a second, as well as crisis residential services and crisis stabilization centers. And I'll explain the differences of those in a minute, but very, very positive. So with mobile crisis, there are several different ways this is being invested. You know, a lot of this, unfortunately, is very top up, where it's by county and what resources are available by the counties. But the state did kick in some money to try to create 14 new assertive community treatment teams across the state, especially in areas where we have mental health deserts and people struggle to access more traditional mental health services. This really, the great things about the ACT teams are they meet people where they are and will come to your home and bring the services to you, so you don't have to hunt out the services. And in New York too, this is a very interesting development. We're going to see how this plays out. It's something we're monitoring, but new teams comprised of mental health specialists and police that are going to be working in the subway system to try to help New Yorkers experiencing homeless and those who have mental illness with homelessness. This is something we've been calling for a version of this. About a year ago, we were on CBS locally in New York City and talking about how what we really need is when these issues in the subway started, bubbling up last year, and of course, it seems like it just continues to get worse, and the unspeakable tragedy yesterday. I mean, that's not a homeless person doing this, but having roaming ACT teams, if there's someone on the train who's disoriented or obviously showing signs of a mental illness, that they can get direct care. And this is not trying to sweep in and take all the people and lock them up, as some have suggested. It's really designed to provide care and try to encourage people to, get into some sort of treatment or some sort of housing and recovery program. Very, very important. As far as, and then just mobile crisis teams and others that the 988 operators can have respond to these situations. So it isn't police. We're really trying to expand more models, like we see the Cahoots program in Oregon and the STAR program in Colorado that really combine mental health professionals, peers, and EMS to respond to these type of situations. So that's so important. But of course, it doesn't matter if it's a police officer, EMS, or a mental health professional who responds to the situation, where if the person needs to get removed from where the crisis took place, we know that currently in too many communities in New York State, the only options available to bring people are either emergency rooms, which aren't designed to handle mental health cases. Obviously, these are emergency rooms are triage. You have to take the most life-threatening cases first, the people who have heart attacks or whatever. Their lives are generally in risk if immediate care is needed. And a lot of times we know that people with mental illness languish in emergency room waiting rooms for days. So that's certainly not the appropriate place. And in too many communities, the only other option is police stations. And that's why, we talked about the criminalization of mental illness, when, that's an option that's the only option available to people, is to bring them into a police station. That's certainly not appropriate either. So we're going to see two types of services. Number one is crisis stabilization centers. There's a couple of examples currently in the state. There's one in Long Island and one in Dutchess County and Poughkeepsie. And these are, designed to offer both mental health and detox services in a much more comfortable, non-hospital-like setting. You don't feel like you're in a hospital. A lot of the rooms where people are feel more like a living room. There are couches, not like a table where you sit on, like the patient table, and it's a much more comfortable experience. And these services, they can keep someone there for 23 hours and 59 minutes, so just under a day. And then they'll try to connect them to community services or residential services, which I'll talk about in a minute. But the state is investing $100 million to create 12 new crisis stabilization centers within the next 5 years. So very, very positive development. And they're also pairing that, if that 24 hours isn't enough, we talked about how inpatient services and what we think about in hospitals, has become less and less available. So one of the ways they're kind of doing a continuum of this care is creating crisis residential services. So residential services are available for people who are coming out of a crisis situation, and maybe going back to the home isn't appropriate for them right away. And this can provide up to 28-day stays in this type of a setting. And this was just introduced, and we're going to have more details about that coming. But both are very, very positive developments, and are going to go, especially when we talk about suicide, right? Someone, has a crisis, they might go to the crisis stabilization center, they stay there a while, and then you send them back. That critical time, following the suicide attempt is so critical. Like I said, you never want to leave somebody alone. So we know that, there hasn't been enough services for people following a suicide attempt. So having these crisis residential services and really give people who are in a very vulnerable state a stable environment, and get them past that initial post-suicide attempt phase is going to be tremendously beneficial and really, really put people back on the road to recovery. I can't talk about how important that is. It's something that we mentioned in the report, and even though we mentioned it, we called for it, we really kind of thought that was going to be a pipe dream and something we weren't going to see, because we know what a struggle it's been to have mental health housing programs and inpatient services. So to see this as an alternative is very, very exciting, and it's really especially going to help people who've been struggling with suicidal thoughts. So very, very positive. Just a couple other investments that are designed to prevent suicide. I'd mentioned mental health housing programs, which is something that NAMI-New York State has advocated for a really long time. Having housing available and housing that graduates people towards independence is so needed. And we talk about all the time how this is a system that has received flat funding for almost 3 decades, and they're operating at about 43% of where they should be. It's probably even less now with what inflation is. So, we've been looking for this investment. Anyone who's been following our advocacy efforts for years, we've been asking for, $100 million to meet this. So actually a little more. We didn't get everything that we wanted, but that's a huge investment. Also, the expansion of Kendra's Law, which is a little more controversial, and we're still trying to figure out what this expansion is going to look like. Take a little bit of a step back. Kendra's Law this year, it was set to sunset. And for people who don't know what I'm talking about with Kendra's Law, it's a assisted outpatient treatment programs where, if someone had been hospitalized twice in a 36-month period and they're struggling to maintain their recovery outside of the hospital, a loved one or their provider could have court-ordered treatment on them, which is very controversial. And we want people to come to recovery by their own means and not be coerced into it. And, we don't want people suffer, decompensating to the point where, the only way they can get treatment is if a court order is put on them. But so there's a lot of ways to look at this. But one of the things that NAMI has always felt is very positive about Kendra's Law is that when there is such a lack of services, that once you have that Kendra's Law order put on you, it puts you on the front of the line, so to speak, for the limited services that are available. And that certainly is a positive, especially for people who have maybe, again, when you talk about 2 hospitalizations in a 3-year period or a 36-month period, the people probably, suicide is a big part of that. And, it has been shown to decrease suicide. So it did sunset this year. Every few years they reevaluated it. And, initially, in the initial budget proposal Governor Hochul made, she made a couple of minor tweaks to it that NAMI New York State thought would actually help the program. It would could streamline a renewal process. You know, we found that, and again, you know, unfortunately, Kendra's Law is only as successful as the programs that are surrounded and available. You know, here in Albany County, it is very successful, and we've had people who talk about how the Kendra's Law saved their life, and you know, help them get a job, help them get their driver's license back, help them you know, find a place to live, and that's all very beneficial. And once they're engaged in it and they get the services and they get recovery, a lot of people, you'd be surprised, actually want that renewed and to stay, so they have that sort of priority. So it would actually make the renewal process a little more streamlined, is what the governor originally proposed. She also proposed letting doctors testify virtually, kind of like what we're doing right now, having this virtual conversation. And NAMI New York State said, you know, those make sense. We've long supported Kendra's Law. These little tweaks would improve the law and make it stronger and really help people. Then in February, the Governor Hochul and Eric and Mayor Adams took it a step further, you know, in trying to respond to the homelessness situation and the violence that you're seeing in subways, which in some ways has been, you know, dramatized as well. And they came up with this 10-point plan for public safety. That one of the points was expanding Kendra's Law, but not really giving too many details of what that expansion is going to look like. So without the details and not 100% knowing what we're talking about here, NAMI kind of stayed on the sidelines about the latest expansion, and we're still trying to figure out exactly what this is going to look like now, because we know the expansion did make it into the final budget. It was one of the more controversial aspects, along with bail reform, which you hear talked about a lot, and really, you heard this year Kendra's Law talked about more than I think I've heard it talked about in all the years I've been in NAMI. So we're still trying to assess exactly where we are with this, what it's going to look like now. Is it going too far? You know, we don't want it to go too far where you can just scoop somebody off the street and you know, slap an AOT order on them. You know, that's, you know, maybe that's not the best thing. And you know, we always said that the mayor too kind of misunderstood it a little bit, and I think a lot of the people he thought he could help through Kendra's Law wouldn't really qualify for it, because you know, most homeless people hadn't been hospitalized for psychiatric things for to meet that criteria. So we're still trying to figure out where this is, but bottom line is that Kendra's Law traditionally has played a role in reducing suicide and getting people who are vulnerable to suicide the help that they need. So there's definitely some positive there, but a little trepidation and a lot to learn about where we're going with this. So those are the other two investments, and that's really where we are right now. So I know I threw a lot of information at everybody, and I'm happy to take any questions that anybody might have, and yeah, talk about any of these issues further. And I'm gonna stop my screen share so I can share some of the resources that I have. First, if people just want a copy of these slides that I've shared with you today, I'll put that right in here for you, so you can click on this link and get access to the slides themselves. A host of panelists, I want to make sure for everyone. There we go. So that will just get you to the slides, and then I want to make sure too that everyone has access to the 988 report, and if you haven't gotten to read that, I'll put that in the chat as well. That way you have access to that and all the information and the stories in there. And like I said, I'm happy to turn it over and answer any questions. I don't know, Pete, if you had any questions, or I don't know if we can open it up to the audience, but
Sure.
happy to answer anything. Or
Absolutely. So the bit of housekeeping I didn't do in the beginning is that for anyone that has a comment or question, you can post it in the Q&A, or you could do the little raise your hand thing. Either way, we'll know and we shall respond. I know a frequent theme we hear are people with loved ones that are really too ill to safely be at home, but not quote unquote sick enough to be in the hospital. And so we also know that a lot of treatment is dictated by insurance and by reimbursement. So anything that brings about any kind of culture change where we look at that, and it makes me think when you're talking about crisis residences, I'm almost envisioning them being used as a step down system for people that are getting out of acute hospitals, because we know our folks might be there a week or two, and ready or not, they're on their way. So I can
If
almost.
they're lucky to get a week. I mean, that's the other thing we hear all the time from families, especially. It's almost so unthinkable that someone, can make a suicide attempt, get admitted to a hospital, and they're out 2 or 3 days later. I mean, my family, this has happened personally. A few years ago, it was actually right around this time. Oddly enough, it happened during the Passover Jewish holiday. My mom had an episode, and she downed a bottle of pills, and she said she did it because the pills weren't working, so she took more. So whether that's what it was, whether it was a legitimate suicide attempt, or it doesn't really matter. Her life was put in jeopardy because of her mental illness. She was, and there were other issues. My stepfather at the time was a difficult personality, I think undiagnosed as well. But she needed, going back into that environment we knew wasn't right for her. We knew that he was a big part of the problem, that wasn't the safest home environment for her. And she was admitted into Cornell Weill Hospital, and 2 days later she was being dismissed, even though we all objected to it. And we know people have this story, the whole, we've heard variations of this. So if she could have had, like Pete said, that sort of transition period to, not get the full intensive services that a hospital might be able to offer, but enough services to get her through that very choppy period, and is tremendously important. And of course, one of the big initiatives that we've been working on as well, which took a little bit of a backseat because with all the attention put on 988 and crisis services, is our Nicole's Law initiative, which came from a family from Putnam County, the Arters, where their daughter Nicole was actually in New York City, and within a 6-month period, she made 5 suicide attempts. And each time she was discharged way too prematurely. They talk about this one time discharged with the paper slippers still on their feet, the paper hospital slippers. And sadly, Nicole was eventually successful in taking her own life and died by suicide. And we're working to prevent situations like that. And one of the things Nicole's Law wants to do is make sure people get connected with services, and then take, that one element of Kendra's Law that I think we all agree is beneficial, which is putting people who are the most vulnerable at the front of the line for services, is that we would try to mirror that. It wouldn't be a court ordered, it wouldn't be mandated services. You still would have to do the services by choice, but if you're coming out of a hospital for a suicide, you should be put on the front of the list. And whether that's community-based services or a crisis residential service where you can stay for another 28 days, we know that will be tremendously beneficial and undoubtedly save lives.
Absolutely, absolutely. And I can tell you from over 30 years in healthcare, we really, really need boots on the ground in our communities, because we know that the sickest members of our community are not the ones that are actively walking through red tape to try to get into treatment. So the more we can get into the community, I think the better.
And really meet people where they are. And that's, exactly. I think these ACT teams and expanding them is going to be tremendously beneficial, and especially for children. Again, especially when a child's in a crisis situation, taking them out of the home and even bringing them to a crisis stabilization center, which is designed to be a lot more comfortable, could just add to the traumatic experience. And you know, we want to try to avoid that at all costs. You never want to separate children from their parents. And you know, using my friend's story here in Albany, brings her daughter to the emergency room in Albany, and next thing you know, she ends up down at Westchester Medical Center 2 hours away in Valhalla, because that's the only place the bed was available. And you're separating kids from their families. And we know that, you know, in any sort of recovery, the family involvement is so important. So, you know, having these ACT teams that meet people where they are and can provide the services where you don't have to even leave the house to get them is tremendously beneficial.
Mm-hmm. I'm fortunate to work with a number of folks who work ACT, and they're amazing. I'm now working, 6 of my colleagues are now working on the SOS teams in the subways.
Oh,
And
yeah, I'm really eager. We'll have to talk separately. I want to hear about their experiences and how that's actually working, and partnering with the police on that. You know, traditionally, the feeling that mixed teams don't always work the best when it's a mental health professional combined with the police. It could get a little confusing who takes the lead in these situations and things like that. And so if this is actually working, it's something that we'd want to replicate. So we're very eager to learn more about this and see how it's actually being instituted on the ground or implemented on the ground.
Mm-hmm. Absolutely.
I think
Let me see. Oh, something popped up in Q&A.
Yeah. So you say that there is laws and help that we are hearing. Why is that there is housing available for people who are homeless and they do not help open the door for people just alive, buildings empty? So I think to try to answer that question, we're looking at a couple different things. You know, I know there's been a lot of, you know, besides the mental health investment, mental health housing investment, excuse me, there is a major investment in supportive housing and those type of programs that, you know, go beyond people with mental health issues, you know, people who are homeless or who are struggling. You know, a home is just such a basic part of life, and having a safe space to live and it's such an important part of wellness. We want to make sure those things are available as well. And we know there are a lot of empty spaces that are not being totally used, and we hope those will be converted, you know, to address the homelessness as a whole, but also making sure that there's specific housing programs for people with mental health issues that really not just provide them a roof over their head and a pillow to put your head on, but, you know, supported services, making sure you take your medicine, that you get to appointments, you know, and then you start in a more congregated setting and graduate towards independence. Mm-hmm. But I hope that kind of answered your question. Anything? No open questions? Okay. And again, I'll put my email in the chat too. If people want to follow up or ask me a question privately, I'm always happy to talk and answer them. So that's my email, and you know, certainly don't hesitate to reach out to me. You know, that's what we're here for.
Absolutely. So for anyone who can't see the chat, it's Matthew at NAMI-NYS.org.
Yes. And well, if there's no other questions, you know, I want to thank everybody for coming tonight. I want to thank, you know, again, NAMI, New York City, Staten Island has always been such a powerful voice in advocacy and leading on these issues. And, you know, your voice is making a difference, and we're starting to see these positives. And now it's making sure that all these positives I've been spending an hour talking about, that this is just the beginning, that it's not a one-time investment. Okay, they checked off the box. You know, we're trying to address decades, not even years, decades of underfunding and what was been a major disparity, a major health disparity, and it's not going to get cured in one budget cycle. This needs to be a continuous process. And that's really where the fight is now, to make sure that this continues, because our providers need that support to deliver the services that we all count on. So, you know, again, we're very encouraged by this budget cycle, but you know, now it's up to all of us to make sure that it's only the beginning.
Absolutely. Thank you so very much, Matt. And the touching tribute for Joni. And I know her sentiment was always fight the fight, hold people accountable, get what we need to get. So
and you know, she held me accountable, you know, God bless her, you know, when this fight over the hospital beds were happening, she called and NAMI needs to do more, and you know, she was on the front lines on that, and to carry on her legacy is a real honor.
Indeed.